for a couple of minutes. Good day, everyone. We are now ready for a terrific session on periventricular nodular heterotopia. We had, though it's not, it's quite rare. The patients are very difficult to manage. There are many difficult cases, and we have two fantastic speakers to show us how they manage these such difficult cases. We have Marc Guenot from Lyon, France, and we have Laura Castana from Milano, Italy. They do share some common knowledge and some common concepts on the issue, but we all know that all patients are different and the strategies vary according to patients. And what we're going to hear is how to define our strategies according to different patients. We're going to start with Marc and follow with Laura. They're going to give their presentations, and as usual, we are going to have a lengthy discussion at the end of their presentations. So without further delay, Marc, would you please start? Thank you so much for joining.
Okay, thank you, Arthur, to have invited me to do this presentation, and thank you to everybody to be here, despite the fact that it is Sunday today. So as you will see, I am the first speaker of this session, and I intend to give a message which could be entitled Periventricular Nodular Heterotopia as seen from the surgeon's eyes. Laura further will give supplementary clinical examples. Here are my disclosure of interest. I am a member of the Medical Advisory Committee of the Dixie Medical Company. And as you will see, I intend to divide my presentation into three non-equal parts. First, I will say some words about periventricular nodular heterotopia in general. Then I intend to explain how we deal in our center in a very practical way with heterotopia if we meet one. And lastly, I intend to have a look at the catalog of possible surgical strategies related to that. The first chapter to start with, as everyone knows, periventricular nodular heterotopia do belong to the group of malformation of cortical developments, and they consist in brain malformation caused by defective neuronal migration, which is well known, but also by abnormal proliferation of cortical progenitors. So this results in the presence of ectopic neuronal nodules lining the lateral ventricle, as can be seen in this typical example from our cohort. Heterotopia can be single, can be multiple, they can be uni or bilateral. They can be associated with sometimes severe other cerebral malformations. And as I read, their main causes are obviously represented by genetic factors, but very often associated to some toxic exposures during pregnancy. Epilepsy is frequent, very frequent. Cognitive impairment may be present, but it is not constant. So, as a chapter 2, once drug-resistant epilepsy is here in a given patient, once at least one heterotopia has been visualized on the imaging, what to do? The answer is simple. The first thing to do is to perform a non-invasive, very classical pre-surgical investigation workup. As usual, we do it, consisting, as everyone knows, in long-term video EEG, MRI, neuropsychological examination, PET scan, etc., etc. So this non-invasive investigation are, of course, necessary, but in most cases, all the cases in our experience actually, they are not sufficient to go straight forward to any surgical decision. So that an invasive investigation is almost always necessary. And the key message of this slide is clearly that SEEG is the key investigation. This is the reason why I put this well-known picture of Professor Jean Talleyrand, who conceived and promoted this technique in Paris in the 60s, so more than 50 years ago now. So at this step of the presentation, I would like to insist a little bit on SEEG in general and as related to heterotopia. We routinely perform SEEG since 1995 in our centers, so that we have more than 700 procedures done. And what is sure is that since former periods, since the older days, we have witnessed many technological evolution. What I mean is that we moved from the good old tracing paper, the good old teleradiography as shown here, which means X-ray sources at 5 meters away from the patient's head, the good old Talleyrand metallic grid, which is shown here also. So what I want to say is that at that older period, an optimal targeting of the periventricular heterotopia was something not easy at all. Luckily, everything has changed as time has passed, and nowadays everything is different, as we do use, of course, a combined use of robot plus OR to perform SEEG. We use MRI plus angio-CT. We have the possibility, as you can see, to perform preoperative imaging controls of the exact position of the electrode. We do an immediate postoperative MRI. So what I want to say is that nowadays, an optimal targeting of any periventricular heterotopia has become the easiest thing to do on Earth, which is a good point for the patient. To go on with SEEG, which is a crucial part of this presentation, of course, in general, everyone knows that SEEG is done to perform long-term recordings, to perform chronic stimulations, okay? In the particular case of heterotopia, it is done to have an exact idea of how the heterotopia can be involved in the epileptogenic network of a given patient. But I would add that, again, at least in our experience, in all the cases, SEEG is also made with the idea to perform further radiofrequency thermocoagulation. And I would say that this should be anticipated a priori in the implantation planning of every patient, which means that we do, in almost all cases, a so-called over-implantation of the heterotopia itself when compared to a classical usual diagnostic SEEG. A second option will be to perform a usual SEEG without any over-implantation, but if coagulation is possible to do, if it is anticipated, this should be discussed with the patient, because in such case, a second SEEG would probably will be necessary. This slide is to explain a little bit what I do really mean by the term over-implantation. So this is something totally technical, but which I think can be interesting for anyone performing SEEG in such circumstances. What I mean, in fact, is that it is possible to implant up to 4 electrodes, very close, one from each other, in the heart of the heterotopia, as shown in these two different examples, again, from our cohort. On the left of the screen, you can see a pre-planning with 4 electrodes in one heterotopia, and on the right column, this is a post-operative, post-implantation MRI displaying also at least 4 electrodes very close one to each other. So 4 may seem quite few or insufficient. I would say that it is better than nothing, in fact, because this allows to have at least 10 coagulation sites, which can be absolutely appreciable. Moreover, it is possible and it must be done to reach the heterotopia itself by using various obliquities. Electrode comes from the upper side, as you can see, from behind, from the lateral side, which allows a proper investigation of the overlying normotopic cortex of the heterotopia. Of course, we do add conventional electrodes on distant normotopic cortex, which needs to be investigated. And all this for what result, after all? What I would say is that SEEG, in almost all cases, does elucidate the problem if heterotopia is the problem. And to show that, I do summarize here the results of one of our studies we did in 2017, and we did publish a supplementary one last week by Random. And it does compare the signal obtained in the heterotopia itself in the local normotopic cortex and in some distant normotopic cortex. So what we found, and these results are shared by many literature data, is that the seizure take their origin in the normotopic cortex alone in a little bit less than half of the cases, in both normal and heterotopic cortex in 45% of the cases, whereas the seizure onset zone is by isolation located in the heterotopia alone and itself in only 6% of the cases. It is classical to say also that the notion of network is crucial for any epilepsy, okay, but especially in case of heterotopia. It is also classical to say that there are very often aberrant connections between heterotopia and hippocampus. And lastly, no surprise that some heterotopic region may sometimes not be involved at all in any epileptogenicity. So all these data are, of course, crucial to move on to the next chapter, namely the therapeutic options which can be proposed for any given patient. So this leads us to the last chapter, what treatment can be proposed. And I think surgical treatment may be divided into 4 different parts. Resective surgery is an option. A second option is, of course, the SEEG-guided radiofrequency thermocoagulation. A third option is represented by the laser interstitial thermal therapy. And miscellaneous techniques should be also discussed, at least. Among them, what about stereotactic radiosurgery? Let's start with resective surgery. Resective surgery can consist, at least theoretically, in removal of the heterotopia itself and by isolation. I must say that I did not find anything significant related to this specifically in the literature. I do not have any experience of surgical removal of the heterotopia alone. And I think it is normal, it is rarely feasible because any heterotopia is covered with sometimes crucial white matter bundles and sometimes also crucial eloquent gray matter. So this is something rarely feasible. Resective surgery can consist in removal of the local normotopic cortex, which we did in some cases of our experience, as shown here. So finally, it consists in doing a very classical cortectomy. It is a temporal basal cortectomy in this particular case I show here, but it consists in performing a classical cortectomy as in any epilepsy surgery. This is something often feasible, depending upon the SEEG data, of course. And it also may consist in removal of some distant normotopic cortex. I will add that finally, it almost always does consist in removal of the temporal major structures, which again is a classical procedure in epilepsy surgery. What about the outcome which can be expected after such procedures? I'm speaking only about removal of normotopic cortex. Again, not about heterotopia itself. I do not have any experience. Finally, the data from the literature are numerous, and it can be summarized by saying that the seizure outcome after such cortectomies is similar to what can be expected after any epilepsy surgery, namely a postoperative Engels class 1 can be expected in 60 to 80% of the cases. So this resective surgery has no particular specificity when compared to any resective surgery for drug-resistant epilepsy. A second therapeutic option is, of course, represented by the SEEG-guided radiofrequency thermocoagulation, also termed thermo-SEEG. It is shorter to spell. I do recall that it consists in taking profit of the implanted electrodes to perform by means of them coagulation of the epileptogenic foci and networks of the patients. So in general, and for heterotopia specifically, such a technique has for sure many theoretical advantages. They are shown here and well known. No supplementary bleeding risks because no need for any dedicated stereotactic trajectory as the electrodes are already there for recording purpose. As the thermocoagulation can accurately fit the relevant zone shape as delineated accurately by SEEG recordings, which is appreciable. As I showed in a former slide, the rather high number of implanted contacts provides a high quantity of available thermolesion sites, which is helpful. As electrical stimulations are systematically performed during any video SEEG recording session, the possible side effects of a lesion can be anticipated in detail, so no need for any test lesion in the operating room, and this decreases the risk. I would add that no anesthesia is required, which is convenient. I also would add, but it is secondary, that it is fast to do, a few seconds by coagulation, and it is also cheap. In fact, it is free, which can count in some cases. So what about our experience in this technique as related to heterotopia? As you know, we did conceive and promote this technique in 2004 in our center, so that we have a global number of more than 300 procedures now. And I recently counted for this presentation, finally, in our center at least, and we are a tertiary reference center, only 14 of them were strictly related to heterotopia. So it is finally not frequent in our daily practice. And I think it is in accordance to what is found in the literature, because finally, the Milano group found somehow 20 heterotopia also in almost 20 years of experience. So this is not so frequent. What about morbidity? As related to heterotopia, coagulation, in our experience, did not provide any morbidity, no mortality. And this is a picture of a typical post-coagulation imaging. So it is positive, but what about the outcome in our experience? Again, no doubt that it is possible to say that thermo-SEEG is more than useful in almost all our heterotopia patients. But I must say I will be a little bit less enthusiastic than for example, the Milanese group is concerning coagulation applied on heterotopia. As you can read, okay, almost all our patients are short-term responders. Short-term means a few months. But 64% only of our heterotopia are long-term responders. Responders means, in this case, 50% decrease at least in seizure frequency. So this is higher than the 48% of our global cohort, but it is far from 100 or 95% or of long-term responders. And among them, 15% do remain very, very long-term seizure-free, which means 5 and more than 10 years in one of our cases, which is again better than the 7% of very long-term seizure-free patient after thermocoagulation. But this remains results belonging to palliative treatment. It cannot be considered as a curative treatment, at least to my mind. A third therapeutic option is, of course, represented by the laser interstitial thermal therapy, which is in increasing use worldwide. I must confess that I do not have any experience about laser. As you know, maybe it is clearly not approved yet in France, at least for epilepsy, so I cannot comment with any personal experience. I found many literature data of high quality. One of them shown here dealing specifically with heterotopia. What can be said is that the side effect rate is higher after laser procedure than after coagulation procedure. The seizure-free rate is also higher, although with a shorter follow-up globally, but it seems to provide a better outcome. My comment, as I look to this picture taken from this very nice paper from the Texan team, is that finally the post-laser MRI control is very similar to what is obtained after coagulation. And this leads me to show this slide of comment. It is almost a slide of possible discussion. Why such a difference in terms of seizure outcome between thermo-ECG and laser, despite the similarity in terms of imaging? Somewhere laser is more powerful than thermocoagulation, but a further follow-up is required, of course. What can be said also is that laser has some drawbacks. It does require a dedicated stereotactic trajectory bearing its own risk, and it is for sure more time consuming and more expensive than the thermocoagulation. So this makes me wonder if laser could be maybe considered as a second-line stereotactic lesioning after ECG for any heterotopia case. What about miscellaneous techniques, and starting with stereotactic radiosurgery? To my mind, the question of applying stereotactic radiosurgery on heterotopia does belong to the vast field of the question, what about stereotactic radiosurgery on non-neoplastic epileptogenic lesions? And I must say it is a daily question in our practice, in our staff meetings. What about stereotactic radiosurgery on focal cortical dysplasia, on heterotopia? In my head, at least, it is not clear. I found at least one literature reference dealing specifically with heterotopia, with rather mitigated results, and taken all in all, the literature data always conclude that there is still some lack of evidence concerning stereotactic radiosurgery in such cases, and that there is need for further trials. But I would be happy to have a discussion about the experience of some of us. IFU, I did not find anything significant related to IFU applied on heterotopia, and it is normal, it is still experimental in epilepsy. I found this interesting paper related to the responsive stimulated neural device, the famous neural-based device, applied on heterotopia, specifically with rather satisfying outcomes, but it is only one reference. And again, I cannot comment on, I do not have any experience. It is, as you know, maybe not approved in France. So in conclusion of all that, I would say by saying that heterotopia are classical, but actually rare etiology of drug-resistant epilepsy. ECG is for sure key for investigation, key for treatment. Resective surgery, which is a classical procedure, is often visible depending upon the SEEG data, but stereotactic lesioning procedures consisting either of thermo-SEEG and or laser therapy, although okay, being to my mind only a palliative treatment, appears to be the most relevant therapeutic option. And I thank you for your attention.
Thank you so much, Mark. I would like now to invite Laura to give her talk, and we will start the discussions immediately after her talk. Laura, would you be so please, Mark, unshare the screen so Laura could share hers. Okay, Laura, then you can go ahead.
Yes.
Perfect. Oh, no, not yet. Yes, just go to full screen and we are ready.
Okay.
Oh,
can
perfect.
you see it?
Yes.
Can you hear me?
Yes.
Yes. Perfect.
Go ahead. Thank you.
So starting, I would say, just to continuing what Professor Guénaud says, we have the idea, obviously, we says that we saw that the network that are at the base of the anatomodegeneration of these epileptic discharge in those patients is very complex. So the identification of these networks needs, it's mandatory, and it's mandatory to identify the epileptogenic zone for the treatment. We published in 2017, we tried to, our group tried to organize the, those patients with periventricular nodular heterotopia, and from the anatomical point of view, we subdivided those patients in 4 groups, with depending on the location of the nodule, if it's single or unilateral, multiple on a unilateral, multinodular, bilateral, or associated in group 4 with other malformation of cortical development. Following to those anatomical criteria, we found that even the seizure onset was different in the different groups. With in group 1, there were more simultaneously, the seizure onset was simultaneously on the PNH and on the cortex, or sometimes just in the nodule. In group 2, there was both simultaneously or in the nodule. In group 3, we found that mostly, more frequently, it was the periventricular nodular heterotopia simultaneously with the cortex, and both of them at the same time, even with the nodule itself. In group 4, all of the patient that was categorized in that group was synchronous activity. The seizure onset was synchronous in PNH and in the cortex. So I would like to show you some clinical patients, some clinical data subdivided in the different groups. So if we talk with about group 1, where we have single unilateral nodule. For example, this is the case of Arnaud with a single nodule on the parietal region on the right. He had something clinical, from the clinical history, have a subjective sensation of levitation and distortion of the surrounding space. And at that point, we asked to we perform a stereo EEG bilateral, because we had to understand the role of the nodule, obviously the role of the surrounding cortex because of the clinical activity and the interictal EEG, and based on some interictal activity that was asynchronous with the one showed on the left side. Even on the right side, we put 2 electrodes on the right side, on the left side too, I would say. At that point, this is the relation, as Professor Guénaud says. We try, obviously, once that you have the chance to do radiofrequency thermocoagulation, you have to put as much as you can the electrodes in the nodule, aim to the, just in case you can arrive to the spheroid with the radiofrequency thermocoagulation, stereo EEG guided. the trace, this is the trace coming directly from the nodule itself and the surrounding cortex. We can see during wakefulness the typical activity of the nodule with this disruption of the normal activity of the brain, and sometimes asynchronous with the other region on the cortex. During sleep, some of the activity tends to synchronize with the activity of the nodule with the rest of the cortex. And then during the seizure, we saw the activity that was simultaneously in the nodule and even in the hippocampal region. In this second seizure, it was really difficult to understand if the seizure starts in the nodule or where it starts first, in the nodule or in the hippocampal formation. We were able to induce the seizure by electrical stimulation with the electrodes, both from the hippocampus, and we registered the activity suddenly in the nodule, and we were able to do the same on the contrary, stimulating the nodule. We have an immediate activity even in the hippocampal formation. So at the end of the conclusion, the idea was that the seizure were sustained by retinal discharge with a simultaneous onset in the lesion and in the hippocampus. And the strategy after that was we can try to, with radiofrequency thermocoagulation in the nodule alone, just not to do both in the nodule and the hippocampal formation at that time. And besides, if the seizure persists, we can do a temporal lobectomy, a tailored temporal lobectomy. So we performed the coagulation in the 2 contact that was explored the nodule, in the 4 contacts for each electrode of electrode LNK that was exploring the nodule. And this is the result, the images at 1 month and 6 months after the coagulation. And the patient is now is 12 years after radiofrequency thermocoagulation and is in Engel class 1A, so is cured at the moment, no seizure. This is another patient, Martina, with same single nodule, but on the other side, on the left side. This is the schema of the implantation. So at the same time, just to understand and to cover not only the electrode, but all the entire network that is that sustain the idea of his epilepsy. So at the end of this, the seizure arrive simultaneously as for the patient we saw before, from the nodule and from the cortex, most of the basal cortex of the temporobasal, and in the cortex in the cingulate gyrus. So we perform at the end of the stereo EEG thermocoagulation in the nodule, in the basal part of the temporal lobe and in the cingulate gyrus. But no response in terms of change of seizure. So at that point, we, based on the stereo EEG, the results of the stereo EEG, we perform a resection in the temporoccipital junction that was with the basal part, one of the most active zone. This is the results of the MRI multiplanar after surgery. No visual field defect, and but no response at all. Seizure remains as preoperatively. At that point, once that we were not be able to destroy completely the nodule with the thermofrequency coagulation, we proposed to the patient radiosurgery on the nodule, and she had done 6 months ago, and now is no seizure, just subjective sensation, but no evidence seizure, but is just 6 months of follow-up. So this is one case, I would say 2 cases from group 1, 1 complete, just 2 examples, 1 cured, 1 not if not just with the destroyed of the nodule, but even after surgery. If we go to group 2, there is with multiple unilateral nodule. Here we have an example of some nodules that is just on the side of the hippocampus, and one more posterior nodule on the right side. This is the schema of the stereo EEG, the implantation of the cortex of the patient, and we perform in that case the seizure around directly from the nodule. There is at the stereo EEG suddenly propagation from the nodule to the hippocampal and the basal cortex. And then this is the results after thermocoagulation of the nodule, and the more anterior and both a little bit posterior in the nodule, and in this just in case one be follow up after more than 6 years. This is another case, more, I will say, multiple nodule unilateral with lots of nodule all along the ventricle. He starts with some visual hallucination, and then some from the clinical part, some more temporal, clinically something that is thing supposed to involve the temporal lobe. So we explore very extensively and trying to reach different part of the nodule with different electrodes all along the nodule with, if you see these, all those electrodes that comes from very posterior part of the brain, trying to reach the different part of the nodules. And at the stereo EEG, we found that all the intralesional contact was very active, and there was a spreading quickly to the cortex, mostly on the occipital part, but suddenly after the occipital part to the hippocampal, mostly toward the more basal part of the heterotopia. So nodules, occipital cortex, temporobasal, and then hippocampus. At that point, we do a lot of thermocoagulation, stereo EEG guided, so all, as much as we can in the nodule, and but the seizure recurred soon after. And then at that point, based on the stereo EEG, we decide to disconnect and to remove a big part of the temporo-occipital part, and is in now is in Engel class 1A with a follow-up that is more than 7 years. If we move to group 3, where the nodules are multiple and bilateral, those are, I will show you two more examples. So this is one with some nodule all along the ventricle on the left side, and some others on the right side. So you have, it starts with some always visual, something in the visual field, and then a sensation of having something in the mouth, a smell not so good, and then something that is more like a temporal involvement from the clinical point of view. This is the exploration that we perform, bilateral, almost symmetrical, with some 2 electrodes that goes from the more posterior part toward all along the ventricle, trying to reach the nodular heterotopia all along the ventricle. And the seizure starts, we saw that the seizure starts with, mostly on the, first on the left side, and then move from the nodule to the hippocampus on the left side, and then in temporomesial and go on the other side on the hippocampus on the right side. So at that point, we coagulate the hippocampus as much as we can of the nodular, the periventricular nodular close to the hippocampus, trying to not going out to spare the fibers of the visual field. And we coagulate even the temporal pole, and now he's in class 1D. It was 18 months, 18 months without seizures at all. Then we try to reduce therapy, and 2 months ago start to have some some sensation and a little seizure after the very big reduction in therapy. This is another patient. Serena is always in group 3, so multiple nodular bilateral, as we can see here on the MRI. She starts with something that she feels in the ear. She hears something on both ear, and then she feels some like a pain and on the stomach, and something that go up. And then she sometimes she fall abruptly down and have some oral automatism. The network in this case, this is the stereo EEG we perform. So mostly on the right side, based on the ictal video EEG, and some electrodes on the other side, just to on the left side, just to sample the nodule and the cortex immediately around. And we at the stereo EEG, we found that the seizure starts in the nodule, but simultaneously even on the temporal neocortex on the right side, and then temporo-anteromesial, and at that point, at that time, I went on the other side. But so just very late in the seizure, the activity arrived. We are able to record some activity on the nodules on the left side. So we decide at the same time to perform a stereo EEG of the nodule and of I would say radio frequency thermocoagulation of the nodule, and even some part of the temporal pole and of the hippocampus, and she had no response at all. So we perform temporal lobectomy, tailored for her based on the stereo EEG data, and she's in class angle 1A after 4 years. If we move to group 4, where the nodules are associated with other malformation of cortical development, this is the case of Laura with a huge malformation, not only the nodule, but kind of polymicrogyria and big nodule, heterotopic nodule. As we can see here, all the cortex on the occipital part is malformated. So the network in this case, this is the schema that the implantation. As you see, there are a lot of electrodes, but I think that as Professor Guénaud says, in this case, we have to, it's mandatory to understand the entire network in those patients. And we have something on just 2 electrodes, even on the other side, to sample the nodule that is on periventricular on the other side, that is in that region. So at that point, the network, we found there is that everything starts from the nodule on on the left side, and then move to the occipital cortex, mesial, and then lateral, and then spread to the temporal neocortex and to the temporal pole. And we found nothing on the right side, on the electrodes that explore the right side. At that point, we perform a stereo EEG, but radio frequency thermocoagulation on the nodule on the left side, and we coagulate even the nodule on the right side, but no response at all. The seizure appeared 3 weeks after thermocoagulation. So at that point, based on the stereo EEG, we decide and we discussed to the patient, we proposed and then realized a very temporal and occipital resection, and this is the results after surgery, and she's in class angle 1A with a follow-up of more than 4 years. So just for show you some results in terms of number, we analyzed 56 stereo EEG among 865 stereo EEG that we have performed up to last December in 56, so that I just do a quick count after the results of Professor Guénaud is 6.5% of our patient with so the patient, those 56 it represented the 6.5% of patient that we explored that have a periventricular nodular heterotopia. So in those cases, in our 56 stereo EEG, 18 do not underwent thermocoagulation because those are patients that were explored before we start to do thermocoagulation. So from when we are able to do thermocoagulation, we have 38 patients that underwent those kind of treatment. Between these, 24 were seizure-free and 14 were not seizure-free. Then we move, 8 of these 14 was operated on. And then we can say that, just to have some percentage, we'll say that 63% of patients that underwent thermocoagulation in periventricular nodular heterotopia experience seizure freedom. And if we analyze the other one that even after surgery, so we have 16 patients that were seizure free. Some of that comes from those, but 5 of these 16 patients, so the 62% of those cases is patient that was not seizure-free after thermocoagulation and becomes seizure-free after surgery. So if we consider just alone the seizure freedom that we achieved just with surgery, we have an amount of 69%. So I will say that there is not a big difference in terms of percentage of seizure freedom if we analyze just those data, but we have to consider that the advantage of thermocoagulation and in general, and we can talk about this even in the discussion. Moving to complication, if it's from the stereo EEG, we have in those patients mainly we have no complication. In the radiofrequency thermocoagulation, this is debatable. I will say I count these 5 patients that have, I will say, contusion. Is something that I will not say there is a complication, but sometimes if we, normally we do a CT scan after in between 12 and 24 hours after the removal of the electrodes, and the removal of the electrode is done immediately after the radiofrequency thermocoagulation. So probably we are able to see something that is just edema and is just, so we cannot consider this a complication, but honestly, I wrote it, but I do not consider a complication. In terms of surgery, we had 2 hemiparesis, but it was in a patient with more fronto-centroparietal PNH. We know that the more anterior is the PNH, in our experience, more complex are the cases. And those hemiparesis, it comes from just ischemic area coming from the ischemic region, from the opercular branches that arrive to the corona. So I will not discuss in terms of these. I have no notice. I will not discuss. I will say about visual field defect, most in posterior, in patients with posterior periventricular nodular heterotopia, because this is not a complication for us. This is an expected, is expected from surgery, so will not consider this as a complication. So in conclusion, what we can say that obviously, as we say at the beginning, and what even Professor Grenaud says, the involvement of the nodule is it must be proved, and the relationship between the nodule and the overlying cortex. In our experience, we have, as you have seen, a patient with multiple nodules, and in those nodules, some of those nodules can be active and some other no. So the epilepsy in those patients is sustained by complex epileptic networks. And it's difficult, very difficult to predict, even in patients that have similar anatomical data, is difficult to predict the epileptogenic zone, and then to predict who can be cured from the different surgical option we have. So this is our experience. Obviously, as Arthur says at the beginning, is the same concept that we share with Professor Guénaud. And I finish, and I will. I think that in the discussion we can be more. We can discuss.
Thank you so much, Laura, and thank you for sharing the screen so that we could start the discussion. I think the first thing we could say, it's fair to say that we need not to give up investigating and treating these patients, because we can help most of them, even in a palliative or in a seizure remission way. I will just add another therapeutic option that will be DBS for these patients installed between the hippocampus and the heterotopia in some of the cases. I have some questions here, but before starting this, I would ask you both, Laura and Mark, why is it so difficult to guess out of the literature where the seizures are coming from? If some of the papers say they're coming from the cortex, the others say they're coming from the hippocampus, and some say it's coming from both of them. Why, from a technical point of view, is so difficult to understand the network?
I think I don't really agree that the question is still alive. I think it is now, the distribution of the seizure origin is now more or less clear. A minority from the heterotopia itself, and a little bit less than half normotopic, a little bit less than half normo and heterotopic cortex. But it is clear now, for a given patient, it is not possible to know it by advance. But logically, SEEG should give the answer for a given patient, to my mind.
Probably the idea, if I can says that, as you have seen, even in my presentation and even in Mark's presentation, we used to put a lot of electrodes. So probably, and all around, probably this is not the same. So we arrived to understand the network because we have the electrodes around. So if you do just, if you put just 2 or 3 electrodes, probably this is not the case. So we used to put up to, we arrived even to, if it needed, to put 20 electrodes in a patient. And probably is not the case in all the rest of the part. Probably this can be an answer.
If so, the other question that is related to this, what do you find in the pathology? I think this comes from Berto, so he could just jump in and ask. But his question was, what do you find in the pathological specimens, the cortical pathological specimens? What do you see there? What is the pathology in the cortex?
Oh, we found in this case, I will check, but we normally we arrive to, in those cases we have a kind of polymicrogyria too. I will check exactly, but we normally we arrive to give a big part of the specimen to the anatomopathologist, so we have frequently the response. I will check suddenly and I will tell.
I was specifically thinking of this patient where you did a lateral temporoparieto-occipital resection of the coagulating the nodular heterotopia. If you found anything there, that would be interesting to know, really.
Yeah, I will give you.
Thank you.
So while we wait for for this, Massimo is there. It's just where is Massimo? Is it in the? Can we bring Massimo to the panel? I think it would be better.
My mentor, one of the mentors.
Let me work on it.
Yeah.
Lots of other questions while we're doing that.
Yeah. There is a question if it's possible to use focal ultrasound to treat this, although there is no FUS guidance around. I would say that there are technical challenges right now for focal ultrasound outside the midline. They are working on this, but at this point, it's not possible to perform adequate lesioning using focal ultrasound more than 2.5 centimeters away from the midline. The other question would be if you believe that, well, Massimo is there. So Massimo, go ahead.
Hello to everybody to participate in the panel. I would like to comment about the targeting in these patients. I think that we must consider that we have 2 ways to look at targeting, electrode targeting. One is the anatomical targeting. It is rather obvious that you target as much as possible with the higher density as possible the heterotopic lesion, because this is the findings that is more attractive for the surgeon. But we have seen from the results of both stereology recordings and of the very recent paper by the French groups that this is a typical kind of network epilepsy. So we have to address also a neurophysiological targeting. And this is, I think, the main limitation of this kind of treatment, because before stereology, we have limited information about electrophysiological targeting. We must only make a hypothesis or postulate that the hippocampus or normally migrated the normotopic cortex of the basal temporo-occipital region, for example, in some cases also of lateral temporoparietal cortex, depending on the case, may be implicated by clinical hints or skull PG hints, but it's very, very difficult to imagine which are the neurophysiological targetings, the connective complexity of this case is really high. So I think this is the limitation, not of the technique by in itself, but of our power, to our ability to imagine an optimal strategy for addressing all the epileptic network. And I think that maybe this is the reason why some patients have a dramatically improvement with a substantial rate of seizure-free patients after RF thermocoagulation guided by steroid, and others do not. Because in those patients, in the not cured patients, we have we don't have addressed the right epileptic network. So I think that in the future we must make every effort to understand before steroid, which is the right exploration strategy for each given patient. So another comment which is very important for me is that it is true that that open surgery provides the same results as those provided by SCG guided thermocoagulations, but as being highlighted by Laura, the burden of surgery, which aims at removing both normotopic and heterotopic cortex, especially in the posterior part of the hemisphere, is represented by an unavoidable visual field defect. So which is not morbidity, but it is just a side effect of open surgery. So we must, I think that we must balance between this consideration, basing that steroid thermocoagulation are completely free of morbidity. I don't know if Mark wants to comment on this, because I think that the same experience is the experience of our French friends.
Would you like to comment, Mark? You need to have a number of questions to go ahead.
Yes, I'm okay with everything, but as far as our series is concerned, no doubt that we do not have any visual field defect, because we have some patients having benefited from thermo-ECG alone, some of them thermo-ECG close to the ventricle plus temporal-basal resection, but this temporal-basal resection did not involve the white matter bundles at all. We do not have any experience with posterior quadrant disconnection for heterotopia. This may be the difference. Visual field defect is something difficult for the patient, so we try to avoid it at maximum.
Okay, so Reese, you got some questions, so I think it would be easier if you address them yourself. So I brought you to the panel. Please go ahead. Are you there? I have to unmute first.
Thank you, Arthur. So one of the questions I have for Mark and Laura and Massimo, I guess, is in those cases where you've clearly identified the periventricular heterotopia as the source of your seizures, and you do radiofrequency, and you don't get the effect that you want, do you think it's because you just haven't gotten all of the heterotopia? And you know, is that it? Or that's I guess my first question.
Maybe you could tell the second one so they could go ahead.
Okay, so the second question is, let's say you have a situation with bilateral periventricular heterotopias, and you know, you have your SEG and you have clearly independent seizures coming, some from the left, some from the right. The periventricular heterotopias are larger on one side, smaller on the other, but they're independent seizures coming from both sides. Would you do radiofrequency ablation of both sides?
If I can allow, my answer is clear for the second question. We do not coagulate on both sides. As far as the first question is concerned, to my mind, I don't know about Laura, but I don't know. Yes, if post coagulation MRI seems to indicate that some extra coagulation will be relevant, so this is discussed. If not, I do not see any other explanation than it is because we could not really understand the network in this particular case. This will be my answer.
So I can comment because in the case where one of the second that we showed, once that she was not seizure free after the girl with the little nodule and the periventricular on the left, with the coagulation that was not completely all the nodule, and then surgery on the external part, no seizure free. We tried with the gamma knife on the nodule just to check if it was that the cause, but once that is not so, I would say, risky, but the idea that we do not understand the network arrived. On the other side, for the second question, we used to coagulate even both on both sides, and I show you the case. Obviously, it depends even if the situation is very, if you have no chance to arrive to surgery and this is the only option that you have, and it corresponds to the clinical pattern. If we arrive to understand well that some seizures arrive from one side and the other, we do the coagulation even on both sides, and we used to do it.
Thank you. We have a couple of questions related to the same issue, so I'm trying to put them together and summarize the thing. What will be, in your opinion, the advantage and disadvantage of radiofrequency coagulation versus LIT? In terms of conformity to the lesions, potential outcome, complications, how do you compare thermal SEG to LIT?
You know, I tried to do this in 2 of my slides. Every technique has some advantages and some drawbacks. It's okay. It is clear in the literature that the side effects are much more numerous after LIT than after coagulation. And it is logistically more complex. But as I said, the seizure outcome seems to be a little bit better. And it is one of my questions, how can it be explained? Because finally, the results in terms of volume of necrosis is not that different. But as drawback, laser is more complicated and more risky. It is clear. As advantage, it seems to be more efficient. This is what I would answer.
I will just say that obviously with stereo EG radiofrequency thermocoagulation, you have both. I mean that you, with the same electrodes that you use for the diagnostic tool, you can say and you can arrive to coagulate. You have the same electrode, you don't have to use something more, and you at the same time have a good diagnostic instruments and surgical tools. Obviously, it depends in the nodule. There is very little in terms of diameter. It depends mostly on the accuracy of your system, because as Mark showed, it's very important that everything is correct, because once that the target of our trajectory is very deep, if you have an error at the entry point, at the target point, you can miss your target. So once that with the electrode, you have the electrode put in the, so each one have to know the settings, his own setting, and just to check for those kind of accuracy. Then with the radiofrequency thermocoagulation that we have, we cannot see have the control temperature, so probably is the only cons that I can consider. But if you do just delete without knowing all the setting before, I don't know if it's so correct for what we explain in this session.
Yeah, we got a session from someone naming it himself as anonymous attendee. So maybe he's just trying to hide it in some way. But the question is, would you consider skipping SEEG in such a patient, doing more minimally invasive procedures like gamma knife or you know, any other things that you could consider before in just going for SEEG after this? Or summarizing it, would you skip SEEG in any case?
No.
No.
No, never. In no case.
This was a very fast no answer.
Well, Arthur, let me expand on that. So in that case that you showed, Laura, your first case, which was very interesting, I think it was yours, with a single unilateral PVH, where it turned out the seizures were simultaneously arising and stimulatable from the hippocampus and the PVH. But in that case, the PVH the thermocoagulation alone was effective for long-term outcome. So you would predict that in that individual case, with a single PVH, that possibly, and I'm not advocating for this, but possibly just treating the heterotopia in that individual circumstance may have worked.
I told you, but the case even after, probably I would say just because the nodule is not completely destroyed by the radiofrequency thermocoagulation, it was exactly the same, just single nodule, but no cured with radiofrequency thermocoagulation, no cure after surgery. So little follow-up after radiosurgery, but we'll see. So this is the debate. It's unpredictable. I will say that it's unpredictable.
Yeah. Another interesting question coming from John. Did you perform any SEEG study in patients who failed thermal EEG before to try to understand why you failed?
Not in those patients, not in periventricular, no. Not in periventricular nodular heterotopia.
We did in ancient times, but it was a quantitative question. You know, first SEEG told us it came mainly from the Heterotopia, and second ECG was done with the idea to coagulate. So it is something different, but this is the only cases we have in which we did two SEEGs.
Do you think that a redo SEEG would help in failed cases?
As I said previously, depending upon the post procedure, the first procedure MRI, but yes, if it is clear that we think we have understood the network, a redo is relevant to my mind.
I wonder if yes? I wonder if the panel would like to jump into the discussion. Guy, Bertu, Christian?
Maybe
we just started with thermocoagulation, so I have no long time experience with it, so I cannot add so much to that answer. Or those answers already given.
May I ask the questions to both of you, Mark and Laura? Does location matter at all? Location of the heterotopia. So, for example, is it easier to understand heterotopia being in the posterior quadrant of the brain or a temporal part than the frontal parts? Does location matter at all in terms of the chance to understand the network and the chance to get the patient seizure free?
I have a purely personal experience about that. And yes, I would answer that the posterior part heterotopia are much more complicated and sophisticated to understand than those located on the frontal side of the brain. This is my personal experience. I cannot give any scientific argument about that, but it is clear, as seen from me.
We were discussing about this with Laura Tassi a few days ago, our neurologist, and she, in her idea, in her mind, is that the frontal part is the more anterior you go, more difficult is the situation. Even from probably we have another patient that is with a single nodule. Frontal periventricular, we coagulate them and not cured. We do a complete resection almost of the frontal lobe, no cured at all, even after a almost complete frontal lobectomy. She says that probably the more anterior one is more complex because it's more related to other pathology, underlying pathology that is more subtle and is more complicated. But we have a lot of posterior. Is very few the ones that are anterior. On the contrary, the single heterotopic nodule away from the ventricle is other things. We have some other patient with just a single heterotopic nodule, not periventricular, that is completely cured after coagulation of the nodule itself.
And in those patients where the normotopic cortex is involved, in what percentage is it very distant to the heterotopia? So, for example, you have an heterotopia in the angular region, so a posterior quadrant, and you have a frontal cortex involved. In what percentage do you see that in your experience?
So in our experience, the more posterior, we saw a lot of time. Frequently, the posterior there is linked to the temporobasal and some temporomesial is frequently hippocampus. And sometimes they arrive to the hippocampus toward the temporobasal, the more basal part of the nodule, the periventricular, just beside the hippocampal formation. This is a good spread to the temporomesial structure.
Mark?
Oh, the same. No, nothing to add.
Did you ever see posterior PNH associated with frontal lobe foci?
Yes, we had at least one case, but you know, it does belong to this more complex global malformations in my personal experience. So it is something a little bit different, I think.
Guy, you're very quiet today.
I think it's a fascinating topic, and it's clear even when Laura was talking about her first two cases that look very similar, and one is seizure-free with radiofrequency coagulation of a single nodule, and the other one has coagulation and surgery and is not seizure-free and is now better with Gamma Knife. I just think that particularly when you look at these recordings, when you have a single nodule and even with an electrode right in the hippocampus and right in the nodule, we still can't tell which one's leading some of the time. And if you can't tell with an electrode, how are we ever going to be able to tell with imaging alone, which, you know, it makes it almost impossible because of the time course difference. I just think there's so much we don't understand about how these networks work and how they communicate and understanding what leads what. And I think it's a fascinating topic. And I also think that both of your talks were outstanding and that your talk should be mandatory viewing, not just for surgeons, but for all of the epilepsy neurologists dealing with this complex topic, because it's what's clear is how much we don't know.
Well, but we do know a lot, enough to treat them, right?
No, we do. And I think it's the other point. I think somebody had a question on this also, which was the issue of of trying to figure out I think actually there was a question about, because it looks like both of you showed really, really good results and results that are in keeping with lots of other lesional epilepsies, maybe not, not quite as good as Liats and things like that, but still very good seizure results overall. And could you maybe comment on which PVH subtypes, when you look at them, you think are going to do better? Because obviously the bilaterals are more complicated and sometimes you get more success there. But when you're deciding and talking to a patient, determining how aggressive to be, which particular situations do you think you're less likely to be successful?
It's hard to say, because I have in mind another case that is a patient that arrived from abroad with a huge situation, a periventricular nodular heterotopia, kind of schizencephaly with polymicrogyria, and we will just say, we just try to do stereo EEG and check if it's okay, but we will not say we can be cured. So we do coagulation and she went not so well, and then we do surgery just on a part of this schizencephaly and polymicrogyria, and she becomes seizure free, and now it's 4 or 5 years. So I tell you, it's really, there is something that is it's impossible to say. So it's some of those patients, even 10 years ago, we should not accept at all. We just say during the first consultation, no way, nothing to do. But from in 2017, we published the case and we arrived to 20 cases with stereo EEG in periventricular nodular heterotopia. Now we arrive up to 56. So because we are exploring a lot of patients with that arrive with those, because we understand that we can give a chance. We are still not know who can be the best candidate. So once that we have thermocoagulation with no risk and things, so we said, let's try. And then this is, but it's unpredictable. It's, I will not say who is the best candidate.
Thank you. We're reaching the end of this webinar. Do the panelists have maybe a last question? Bertil, Christian, Guy? If not, I would like to thank so much for Laura and Mark for joining us here. It was a wonderful session. I'm pretty sure everybody learned a lot from it, and hope you are going to be together in the next webinar, and see you soon.